So what do we do if our patients' symptoms do not match severity of their parenchymal lung disease? Let's talk about evaluation for presence of pulmonary hypertension. There have been a number of studies trying to look at different diagnostic modalities which would help clinicians to predict presence of pulmonary hypertension in patients with parenchymal lung disease. This particular study came from RISE IIP dataset that looked at the effectiveness of RISE-CGUAT in the treatment of pulmonary hypertension in patients with interstitial lung diseases. It is one of the largest datasets that we have, 229 patients, and this particular analysis looked at correlation of FVC, so forced vital capacity, and mean pulmonary pressure. And as you can see on this scatter graph, there was really no correlation. There are a number of other studies that looked at correlation in various pulmonary function tests, so specifically FVC or vital capacity and presence of pulmonary hypertension, both by echo and right heart catheterization and smaller data sets, and all of them failed to show any correlation. What that means is that patients who have preserved pulmonary function tests may develop pulmonary hypertension in the setting of interstitial lung disease. And so can patients who have quite limited restriction based on pulmonary function tests as well. This study looked at radiographic presence of fibrosis in patients who have interstitial lung disease and mean pulmonary pressure by right heart catheterization as well. And in this data set, similarly, there was absence of correlation between the two. If the CT scan is not useful when we look at the parenchyma, is there anything we can use by ordering the test that would help us detect presence of pulmonary hypertension in patients with chronic lung disease? And both in COPD and ILD, the answer is actually yes. So there are several studies that looked at pulmonary artery to aorta ratio and examined both ability of this ratio to predict presence of pulmonary hypertension and also looked at survival. So there are two studies that were done in idiopathic pulmonary fibrosis showed that the PA to A ratio of more than 0.9 predicted presence of pulmonary hypertension in a data set of about 180 patients. And it also showed that the patients whose pulmonary arteries were enlarged were at risk for mortality, increased mortality. Another paper that's not presented here also showed that these patients are at risk for acute exacerbation of their interstitial lung disease. Similarly, in COPD, the ratio of pulmonary artery to aorta, and the ratio in this particular paper was 1, predicted both hospitalizations due to COPD exacerbations and mortality in patients with underlying COPD. So CT scan can be very useful, and when enlarged pulmonary artery is seen on the CT scan in patients with chronic lung diseases, pulmonary hypertension is one of the things that should be considered, especially when someone is coming in with worsening symptoms. So what about the 6-minute walk test? Well, there are several parameters in 6-minute walk test that have been looked and in evaluation of their ability to predict pulmonary hypertension. And one that is frequently used in clinic and can be easily used is something called heart rate recovery. So heart rate recovery is a difference between heart rate at the end of the 6-minute walk test, so minute 6, and 1 minute post-recovery. And what the study showed is that the absence of fall in the heart rate more than 13, so if patients are unable to bring their heart rate down quickly enough, so by 13 beats in that 1 minute, is associated with both decreased survival and presence of pulmonary hypertension. So that's something that we quite commonly use in our practice. So what about echocardiogram? So this data looked at 110 patients who had concomitant echocardiogram and right heart catheterization and compared the degree of elevation in RVSP, so right ventricular systolic pressure, and mean pulmonary pressure and systolic pulmonary pressure by right heart catheterization. And you can see that the echocardiogram is actually not that great if all you look at is the RVSP. Only 40% of cases were accurate, and overestimation of pulmonary pressure, so the measurements were very likely, as were underestimation. So about 20% of patients had their pulmonary pressures underestimated by the echocardiogram. Now, some of the data that I'll show you a little bit later will talk about other markers of actually RV dysfunction and their utility in prognostication. RVSP is a little bit tricky. Echocardiographic quality is very important, as well as estimation of RVSP. We do know that RVSP can be elevated in patients who have biventricular heart failure in the setting of diastolic dysfunction. So just because RVSP is elevated does not mean necessarily that a patient has pulmonary hypertension related to parenchymal lung disease. But what it does mean is that more follow-up needs to be done. So just to summarize some of the data that I have presented and some of the data that has been looked at in other studies that suggests that a patient with underlying chronic lung disease may have pulmonary hypertension is presented on this slide. So if we go through it one by one, in pulmonary function testings, diffusion capacity less than 30% of predicted has been associated with presence of pulmonary hypertension, as well as worsening of diffusion capacity over time, especially in the setting of preserved lung volumes. 6-minute walk test, I already mentioned impaired heart rate recovery, marked desaturation or worsening desaturation over time, and severely reduced or again worsening over time 6-minute walk test distance should alert someone that the pulmonary hypertension may be developing. I showed you some data on a CT scan, so increased pulmonary artery to aorta ratio. We also look at the RV to LV ratio, just like in patients with group 1 pulmonary hypertension. So when right ventricle is getting bigger, so the ratio is more than 1, pulmonary hypertension is something that needs to be considered. And then on echocardiogram, there are a number of things that we suggest that you look at. So I mentioned RVSP already, right ventricular dilation, so looking at the diastolic diameter of right ventricle. So usually the cutoff value is 3.4 centimeters. Reduced TAPSE, less than 1.5 centimeters. And in the 3-dimensional echocardiogram, reduced right ventricular fractional area change, so less than 44% is a cutoff. And then in the laboratory, elevated BNP. So BNP is one of the markers of the distended right ventricle. And when BNP is elevated, again, pulmonary hypertension should be considered. So what about right heart catheterization? I alluded in my talk already that right heart catheterization is very important for a variety of reasons. One of them is obviously to confirm the diagnosis. Again, echocardiogram, although it's a great screening tool, it's not a diagnostic tool for presence of pulmonary hypertension. Left-sided heart disease is very common in this patient population. It does have to be really considered if there are certain findings on echocardiogram, like, for example, enlarged left atrium. If a patient has atrial fibrillation, diastolic dysfunction becomes more common, and it needs to be actively sought out on right heart catheterization. So there are different ways to evaluate it. One of them is fluid loading, another is exercise. The other reason to do right heart catheterization is look at the right ventricular dysfunction or function. Again, on the echocardiogram, we look at just size and the function of right ventricle, how dilated it is. On 3-dimensional echocardiogram, we can look at the RV ejection fraction and the fractional area change. On right heart catheterization, we look at right atrial pressure and cardiac output and cardiac index. And obviously, elevation of mean pulmonary pressure will indicate severity of the disease. And there is some data that suggests that as pulmonary pressure rises, so do both exercise limitation and mortality. So how do we determine if someone has group 1 pulmonary hypertension with a little bit of parenchymal lung disease or group 3 pulmonary hypertension? And this is actually not very easy to do. There is a lot of gray in this area. This table is meant to help clinicians to put patient in one of the groups based on both clinical factors. pulmonary function testing, CT imaging, echocardiography, as well as hemodynamics. So for group 1, presence of identified group 1 risk factors such as connective tissue disease, HIV, liver disease, and drug toxin exposures, among others, is something that favors group 1 disease. Mild restriction on pulmonary function tests, low diffusion capacity in relation to restriction, mild parenchymal involvement on CT imaging, significant RV dysfunction, and also severely affected hemodynamics all favor a diagnosis of group 1 disease in presence of mild concomitant interstitial lung disease or COPD, so parenchymal lung disease. On the other hand, absence of group 1 risk factors, severe restriction on PFTs, diffusion capacity which is proportional to restriction, severe parenchymal involvement on a CT scan, mild RV dysfunction on an echocardiogram, as well as mild elevation of pulmonary pressures with preserved cardiac index favor group 3 disease. Having said that, there are definitely groups of patients in both COPD and interstitial lung diseases that have what we think is a group 3 pulmonary hypertension that have severely affected hemodynamics with moderate to severe RV dysfunction as the disease progresses. So as I said, a little bit of gray in this area.